Morning, everyone. Today we'll be discussing on hypogonadotropic hypogonadism. I've unmuted. Few interesting cases on hypogonadotropic hypogonadism. So before proceeding with the cases, we'll just yeah, I'll just brush on what are the things that we see and how stimulation is different in hypo patients, and what are the things that we expect when we are stimulating hypo patients. So hypogonadotropic hypogonadism, there are multiple etiologies. They're usually present with ovulation disorders. They have low level of endogenous gonadotropins and estrogen deficiency because there is lack of FSH-LH, no ovulation happening, there's estrogen deficiency. So we see two types of entities, most common being congenital form or late onset, which has got functional causes. So congenital hypo is caused by deficient production, secretion or action of GnRH, which is the most and key neuropeptide which is important for HPO axis. The congenital form U is one of the most common form of hypo, which accounts for about 40 to 60% of all cases. When it is acquired, they usually present with secondary amenorrhea, or they have this low estrogen levels, and it is because of secondary causes such as any tumors. Because of those reasons, they present with low BMI also. So the secondary causes being the infiltrative disorders of the hypothalamo-pituitary tract, like lymphocytic hypocytitis, then histiocytosis, sarcoidosis, certain space occupying lesions such as pituitary adenomas, craniopharyngiomas, and other CNS system tumors which can compress the pituitary. Adult onset isolated gonadotropin deficiency, meaning they don't have any other associated features or other structural or functional abnormalities in the other organs. They only present with specific isolated gonadotropin deficiency that is usually seen with other systemic, secondary to certain systemic disorders, drugs, prolonged use of certain drugs, then any functional abnormalities within the pituitary, or it could be an idiopathic cause. So most common among that being hyperprolactinemia, that itself can suppress the pituitary function, leading to an isolated hypo situation, or it could be sometimes nutritional disorders or an undiagnosed chronic illness which may affect the hypothalamic GnRH pulse frequency, leading to hypo scenario. Or hemochromatosis after can affect hypothalamic and the pituitary region, which could lead to progressive isolated gonadotropin deficiency, seen in case of thalassemia when there have been prolonged iron supplements, undiagnosed ones can present like this. Even drugs that can be these drugs, when they are stopped, when they're given for a long period, that can suppress the pituitary, leading to hypo, but these are something which is reversible, and after stopping the drugs within few months the pituitary action can restore itself. So they are like include opioids, prolonged use of glucocorticoids, psychotropic agents like phenothiazines. All these things can affect the GnRH pulse frequency. So first talking about the congenital hypo, they can present solely as congenital GnRH deficiency, or at times they may be associated with other developmental anomalies such as cleft lip, palate, any dental agenesis, ear anomalies, congenital hearing defect, and renal agenesis or skeletal abnormalities. So it is a varied presentation. Either they can present only as hypo, or they can have other structural abnormalities also, and usually present as primary amenorrhea, where the puberty needs to be induced by giving HRT in such females. And estrogen treatment, when we give it HRT for at least 3 to 4 cycles, the uterine size can be increased in them. Then therefore it is preferably better to give estrogen progesterone therapy in them to increase the size of uterus, but that will not provide ovulation. But when their concern is infertility, or when they want to conceive, that is when we'll have to treat them with gonadotropins. So they usually present with persistent FSH deficit, and there is, in case of isolated HH hypo kind of scenario, they present with persistent FSH deficit. Because of this, they appear to have diminished ovarian size, reduced AFC, and because of this, the number of oocytes retrieved are also lesser in such cases, and they present with low levels of FSH and LH. And during their stimulation, down regulation by either to giving a GnRH agonist or antagonist is not required, because already pituitary is not functioning. So when we are stimulating a patient of hypo, we need not give an antagonist or an agonist, pituitary suppression. And stimulation can be started on any day of amenorrhea or after a progesterone estrogen withdrawal bleeding. the best would be to give 2 to 3 months of priming by with estrogen progesterone pre-treatment. This will improve the response mainly with the endometrium, because for a long period of estrogen deficiency the endometrium would have got completely thinned out. So by giving the 2 to 3 cycles of HRT will increase the uterine size, the endometrium also becomes responsive and you'll be able to track it. So after that, when we go for stimulation, we get better results. So in your stimulation, because there is deficiency of both FSH and LH, a combination of both FSH and LH is best. If we are using both recombinant, we'll start with 2:1 ratio, like recombinant FSH and recombinant LH. But in the later half of the stimulation, in the late follicular phase, you can increase the LH content and make it 1:2 or 1:1 also would be sufficient. If you are using RLH, we usually don't go for recombinant LH. The dose will not be more than 150 or 187.5, because again we might reach off the LH ceiling effect. So carefully we have to use RLH. Okay. And predicting, and most importantly, what we have to see in this hypo patients is they tend to have lower AFC and lower AMH. Based on that, it is not possible to predict their ovarian response because of the prolonged suppression. Like what we see in other normal responder patients, we based on our AMH, AFC, we can decide the dose, all those things. But in these people, it is very difficult to assess the response based on the ovarian reserve testing. So ideally we start with high dose only, because the response is very slow in them. They require higher dose of gonadotropins, but they do respond very well after a few days of stimulation. So predicting the ovarian response of treatment of patients with hypo is difficult because of low level of gonadotropin. They have small ovaries and amenorrhea, which will tend to look like poor ovarian response patients. But we cannot completely rely on ovarian under reserve test in hypo patients. So this is one of the study which was published in 2019. Only in this study, they have given that though the patient was hypo and they kept the controls, the AFC and AMH was slightly higher, but the AFC did not vary significantly. And of course, FSH and LH were less only in the hypo group. This is another study which was published in 2006 to look at the stimulation, how was the stimulation went on in these patients, where they compared hypo with unexplained infertility. Here we can see that the day of stimulation, here it was an average of 14 days. Here it was about 11 to 12 days, which was statistically significant. So hypo patients, they can go for prolonged, the duration of stimulation is high in them. Total gonadotropin dose definitely high in hypo compared to normal responders. Peak E2 levels also is less in hypo patients compared to other group, which was also statistically significant. But if we look at the other factors, though the number of oocytes were lesser compared to unexplained infertility, but the overall pregnancy rates did not vary much. We can see here pregnancy rates did not vary much, and in fact the implantation rate and all was good. Okay, so what we see here is only we might have a delayed response, we might need higher dose of gonadotropins, but the endometrial thickness, they respond very well once the estrogen supplement starts, or the estrogen production starts. And on the day of trigger, we tend to see a lower level of estrogen in them compared to, if there are about 5 to 6 or say about 10 follicles that is growing, and we see it will go more than 3000, but in hypo patients it might come less than 3000 also, so it might not correlate so well in them. Okay, most of our ovarian reserve test, estrogen on the day of trigger might not correlate with the number of follicles in hypo patients. And but if you look at the clinical pregnancy rate, it does not really vary compared to the other group of control patients or normal responders or unexplained infertility. There's another study which was published in 2021, where they compared the baseline characteristics between the hypo patients and premature ovarian failure who have gone into low ovarian reserve patients, to see how different both are, because they both of them present with low AFC, low AMH, and the response is also slow. But here if we see, the FSH was definitely lower in the hypo group compared to POF group. LH also lower. AMH, though it was little better in them, was not statistically significant. Similarly with AFC also, they were little better compared to POF group, but it was not statistically significant. If you look at the gonadotropins, though the AMH and AFC was slightly higher compared to them, the total gonadotropin dose was significantly high. Here it was about 5600, here it is about 4000. And peak E2 levels also, since it is POF, it has come like very low, because they'll hardly have 2 to 3 follicles in them. Though the AFC, if you look at the average AMH of about 0.46, For 0.46, they respond very well. More number of follicles grew, and because of that, the average E2 was about 3,300. And total number of oocytes retrieved were higher in hypo compared to POF. In previous group, what I showed was it was a comparison between the unexplained infertility and POF and hypo. So in them, because they have normal reserve, here we are comparing with somebody who has low reserve, and when we look at that in hypo, the response is better compared to them, and we retrieve more number of oocytes. Though initially they look like less, and fertilization rate was also good in them. So AMH and basal AFC has limited value in women with hypo regarding the prediction of ovarian reserve and ovarian response to stimulation. So they will require higher doses of gonadotropins. That could, what they say is not to give up initially seeing that there is no response, better to increase the dose and prolong the duration of stimulation. And a few points on this. Serum E2 concentration may not be the most important index for oocyte maturation during stimulation, and suggests that oocyte maturation was quite normal even in patients with low E2 and high P4 conditions. This is particular to hypo patients only. So even if serum estradiol concentration did not increase compared to the number of follicles that we had, the number of M2 oocytes could be obtained, and it was a good number, like it was correlating with our follicles that had grown. And in isolated hypo have variably low circulating levels of AMH, and that the severity of AMH deficiency is related to the severity of FSH deficiency. These patients tend to have low ovarian volume, low AMH, low AFC, but should not be considered to indicate a poor childbearing prognosis, as fertility can be effectively restored by both pulsatile GnRH or by giving a gonadotropin administration. So if you look at the overall pregnancy rate per embryo transfer cycle, when it is compared with the other group like the tubal infertility or male factor, it was almost comparable, which is about 46%, same as we see in other group of infertility patients. And even fertilization rate was also comparable between the two groups. Say they had about 72%, implantation of 36, live birth rate of 51%. So they have better prognosis. It's just that we need to give higher dose of gonadotropins. So first I'll just present this case to you. I'll be discussing two cases here, and after that if you have any doubts we can do the discussion on that. So the first case is she's Mrs. A, 29 years, married to B, who's 42 years, presented with history of primary infertility for about 10 years. From her history, she had irregular cycles since menarche, where she used to get her periods once in 60 to 80 days, but most of the cycles were through withdrawal only. So basically, she was kind of primary amenorrheic types. Otherwise, she did not have any other significant medical history. There was no comorbidities, nothing else that could suggest the cause for her hypo. So probably we would diagnose this as idiopathic when we don't find any other functional causes there. And family history also, her mother was diabetic on medication, otherwise rest all the things were normal. And husband was occasional alcoholic. His father was hypertensive on treatment and mother diabetic. Otherwise, he did not have any other features. Previously, she was tried with few cycles of ovulation induction and timed intercourse, where she had ovulated once with gonadotropin stimulations, but then she did not conceive. IUI was tried, she did not conceive. And later on, before proceeding with IUI, she had undergone hysterolaparoscopy, and normal findings were seen in her. So after that, on examination, her BMI, height, secondary sexual characters, they were all fine because she was on routine HRT. Uterine size was also fine. It was about 6 into 3.9 centimeters. There was no hypoplastic kind of features. And ovarian reserve, there was follicles of 8+5 in both the ovaries, not severely compromised. And rest of the parameters were okay, except TSH was 3.1 and OGCT was 152, but further evaluation her sugars were normal. Prolactin was also within the normal range, but her AMH was 3.2. And baseline FSH 0.7, LH 0.28, E2 45. Sometimes we do see this kind of scenarios when patients have been treated with prolonged OCPs. So what if the patient has taken previous cycle, 2 cycles or 3 cycles of OCPs, and we see something like this and we cannot really attribute any specific cause for hypo, stop the OCP, wait for her natural cycle if she gets a natural cycle, and then we'll repeat FSH-LH. If it increases, then it is fine. If it does not increase, we'll consider it as an isolated category, and then we can start treating her like hypo. And yeah, husband did not have any significant features except that he was little obese, and investigations were fine. His semen analysis showed teratozoospermia with normal count and motility. DFI was not done, and normal forms were 3%. So this is the stimulation for her. There were 8 follicles on one side, 5 follicles on the other side. So the FSH, LH both were less than 1. E2 was 45. So stimulation we started with HMG, a combination of FSH and LH. Because she was only 26 years, BMI was normal, so 300 was chosen to start. And the by S4 of stimulation, there were few follicles which had started increasing, but for this the E2 was only 103 and LH had become less than 0.1. So we continued the same dose, and the next day the response had increased better. The follicular growth, there was about 1 to 2 millimeter per day which was growing, considered adequate. But here we have put ANTAC because if at all any rise happens later on because of increased E2, because of a fear we have put. But if she's been confirmed hypo, there is no hard and fast rule that we have to add antagonist in such cases. But there is no harm in putting also, that will not affect the response. To be on the safer side, if you're worried that later on she might, because of the increased E2, by any chance if there is an LH surge, you need to add ANTAC. Otherwise, you can monitor her LH levels. If it is very low, you can avoid giving an ANTAC to the patient. E2 was very high, not very high, not that day. Next day, it would have definitely become more than 350 because there were 2 follicles which were 12 and one was 10. That would be more than 350. To be on the safer side, we have added ANTAC. Otherwise, we need to keep monitoring our LH levels and see that it does not increase. That's all. Sometimes what happens if it is completely congenital hypo, or if she's a craniopharyngioma where hypophysectomy has happened, then it is a different thing. That definitely there is no LH rise. Partial hypo, yes. In such people, it will be like a little gray zone. Might increase when E2 goes more than 1000, then it might cause slight increase in LH. So in such cases, better to start off antagonist. Not going to do any harm. Or else you'll have to monitor LH very regularly. Okay. So with the start of antagonist, we increased HMG to 375. So here you can see if she were to be a normal responder with normal FSH-LH for her age of 26 and BMI of normal, AFC of 8 plus 5 and AMH of 3, a dose of 225 would have been sufficient in her case. But here we went on till 375 because of hypo scenario. And stimulation went on till S12, day 14, and on S12 there were about 1, 2, 3, 4 follicles on the right side and about 2 to 3 follicles on the left side, and for so many follicles the E2 was only 1630. So she was triggered with HCG because again leupride trigger, she might not respond. If there is no sufficient LH rise, then there is no final oocyte maturation. So therefore HCG trigger is the option here. And OPU was done at 35th hour with double lumen, and we retrieved 9 oocytes. So though E2 was only 1600, 9 oocytes, so that is what we are telling. E2 and AMH AFC does not correlate in case of hypo cases. And semen parameters were fine, so ICSI was done. Out of 9, 8 fertilized, 8 cleaved, and we got about total 6 grade 1 embryos which are frozen now, and her transfer is yet to be planned. Like it just happened recently, so put this case. So for next, once we have frozen, for transfer we'll start with again on HRT, our usual HRT protocol. What we start, estrogen combination. We start with about 6 to 8 milligram in the starting, and then call her on day 9 or day 10 of the cycle. See the scan. Look if the endometrial thickness is increased to 7.5 to 8 millimeter. If it is there, then we do not increase the dose. We'll continue the same dose. And with that, monitor the blood levels, blood flow to the uterus also. Look at the PIRIs of the uterine arteries, then zone of the blood flow. All those things will be monitored. If it is not sufficient, adding little bit of sildenafil or increasing RG-preg, all those things will improve the blood supply. And then call her after 2 days again to assess the blood supply, and if thickness is not increased. Once the endometrium is optimum, we can further start the progesterone and plan embryo transfer for her. They usually have good prognosis if we transfer good quality embryos. Okay. And this is one case. There's another case. I'll be reading out the next case. She's a 26-year-old female, married to a 33-year-old male, married life of 3 years, presented with primary infertility, and her first menarche started at the age of 17 years. Like the first period was at the age of 17 years, and that was induced by HRT. She had not got her periods initially, and after that, her cycles were like once in 1.5 to 2 months, and all of them were withdrawal bleeding only. She never used to get her spontaneous cycles. Otherwise, there was no coital dysfunction or anything among them. And her rest of the past history, everything, there was no significant medical history in the past other than this. And her sister, who was married for 4 years, also presented with infertility, but she was not properly evaluated, so we didn't know whether she had similar issues or not. And 38-year-old, and her mother was about around 40 years, and she was still menstruating. Her mother had regular cycles only, and husband did not have any significant features. And previously, she was evaluated outside, and she was diagnosed with hypo when she came to us itself. And outside, her FSH was 0.1 and LH was less than 0.1. So she was a frank case of hypo. And then her other investigations. On examination, she was fine. Secondary sexual characters, everything was okay, but just that she had hypoplastic uterus. So whatever HRT that she was taking, like might not be sufficient. So she had this hypoplastic uterus, where her AP or longitudinal measurement of the uterus was 3.5 centimeters, and transverse was about 2.7 centimeters, and AP was 15. So 1.5. So this is definitely an hypo. Anything less than 5 into 2 will come into hypoplastic uterus. Ovaries had volume of 5 cc one ovary, and the other one is 7 cc. Other one was about 2 cc. Follicles were about 4 and 5 in each ovaries. And then we went ahead with further investigation. CBC, everything had blood count, everything was normal. Sugars were normal. A routine karyotypic screening done, that was also normal. And later on, FSH came as 0.6, LH less than 0.1, a hypo type only, and then AMH was 1.7. So 5 plus 4, AMH of 1.7, low ovarian volume, and hypo. Exact cause could not be found out. So proceeded with the physician opinion was taken because she was thoroughly evaluated previously for her hypo, and no cause could be found. And husband factors except mild teratospermia, his semen parameters were normal. So decided to went ahead proceed with direct IVF stimulation. But prior to the stimulation, she was given 3 cycles of HRT to improve the uterine size. So when we give this HRT, 2 things we're going to monitor here. One is with every cycle, we'll see whether there is any increase in the uterine measurements. And also before starting the progesterone, we give like 25 days of estrogen, and last 10 days the progesterone supplements will be given. So before starting progesterone, the last cycle of HRT, you can call her, see how the endometrium is growing in response to the HRT. So that will give you a fair idea how the transfer is going to be made. So that one, once we completed 3 cycles of HRT and hysteroscopy was done to look for the cavity size, whether it is looking too small or we'll have to go with a single blast transfer. And then it had increased in size, and it was fine. It was adequate for implantation on hysteroscopy. And then stimulation was started for her. So after 3 cycles of HRT, I'll just tell the uterine size. The uterine size was 6 into 2.6 into 3.3 centimeters, which was 3.5 into 1.5 into 3 has become 6 into 2.6 into 3.3 centimeter. So there was a significant increase with proper 3 cycles of HRT. And AFC remained same, 4 plus, by that after 3 cycles, it was like 4 plus 3 what we could see. So stimulation was started from day 2 of the cycle. So we started with 300 international units of menopur. After 4th day, on S3, her E2 level was 32, and most of the follicles were in the 5 to 6 range only. Okay, and then again S5, the dose was continued. Slowly, it started increasing on stimulation day 5, where about 7 to 8 millimeter it had become. And then by S7 of stimulation, her follicles reached size of 10 to 9 to 10 And on 7th day of stimulation, the E2 was 153 and LH was less than 0.1. So this is how slow they can respond. So we should not give up saying that, okay, she's not responding, we'll cancel, we'll postpone to the next cycle. Instead, just increase the dose a little bit and continue the stimulation for prolonged period. better to go with a flexible protocol only. In her case, we started antagonist because we didn't want to monitor LH more frequently if at all it rises. And on 8th day of stimulation, antagonist was started. That time her lead follicle was 13. Rest of the follicles were in the 11 to 12 millimeter range. And the stimulation was continued with 375 international units of molecule for her also. The stimulation went on till 13 days. So on the 13th day of stimulation, her E2 level was 1895, and the number of dominant follicles, lead follicles she had were 8 follicles were bigger in size. More than 17 mm, there were 8 follicles. For 8 follicles, her E2 was only 1800, LH less than 0.1, P4 1.1. Okay, so again here also we see that it does not correlate with each other. And then of course HCG trigger was used. So with HCG trigger, the pickup was planned at 35th hour, and 35th hour the pickup was done, and then we retrieved a total of 6 oocytes. Out of 6, all 6 were mature oocytes, and ICSI was done, and all 6 fertilized, and all 6 formed grade 1 embryos. So here what we see is the M2 retrieval rate is good in them, though they have less value of E2 on the day of trigger. Second thing is the fertilization rate is good, and chances of getting grade 1 embryos are also good in them. Okay. So, and then the FET was planned the next coming cycle. In FET, we did a sequential transfer for her. So we did a blast transfer directly. There were 2 blasts. All 3 embryos were kept for culture with 2 blasters because we didn't want triplets in her case, definitely. So kept it for blast culture and transferred to blast, and she conceived a singleton pregnancy after that. So this is how we proceed with hypostimulation. And a small note in case of males, how do we manage males with hypo? Again, the treatment with males also giving them HCG and HMG injections twice or thrice weekly. But here in them also the duration of the gonadotropin treatment will go on till 6 to 12 months. Usually present with azoospermia or severe oats with small testes, low testicular volume, and when we check the FSH-LH levels will be less than 1 or 1.5. On providing the supplementation, they do respond, but there in case of males the prognosis is poor. Whereas in females, when we supplement, the prognosis is better. In case of males, the prognosis is poor, and they require a very prolonged treatment for about minimum 6 to 12 months duration. And one more point I want to add here is in the in case of female, the challenge what we face is the risk of OHSS. Though we are using only HCG trigger, there's no option for agonist trigger. There could be a chance of OHSS, but whatever case studies have been proposed, have been seen so far, the risk of OHSS has been very, very minimal. Though at 3000, if at all she has multiple follicles diagnosed at a very young age, and we have stimulated her and pickup has been done, though more number of oocytes are being retrieved in that case, the risk of OHSS remains very less in them. Okay, because of gonadotropin deficiencies only, and they can be easily managed. So far, if you look at the case series that is being published in meta-analysis, they say there is very less chance. There are only 2 cases where the patient has gone into severe OHSS. So far, only 2 cases, that too when fresh transfer was done in them. So in hypo, try to avoid fresh transfer as much as possible, because the endogenous support is not there. Then you will have to give too much of exogenous support. So better to go with a frozen embryo transfer in case of hypo. So with this, I think I've covered most of hypo cases. I mean, at least you got what is to be discussed. If you guys have any other doubts, you can ask me.
Ma'am, in this case, how do you
Yes.
decide that you have to give HMG 300? Because initially you told that we start with 150 or to 187, because we don't calculate it by AFC age or AMH. So how do we
Yeah.
decide that it has to be 150 or 300 or?
No. In them, in hypo patients, 150 might not be sufficient. It's too less for them. It's usually PCO will require this kind of dosage. And knowing the scenario that she is hypo, you can start with the maximum dose of 300 itself. And if she's obese to start off, like suppose her BMI, say she's about 30 years and her BMI is more than 30, you can still start with 375 international units. So your starting dose in hypo patients and it should be a little higher dose. So never start with 150 or 187.5, then they might not respond. So it is the main thing that you have to keep in mind is they require higher gonadotropin, they require prolonged duration of stimulation, and they have good and in case of females they have got good prognosis. So these three things you have to keep in mind.
And ma'am, how do we decide that when we have to increase the dose? Because you start with 300 or 375. Do we
Yes.
need to increase the dose after seeing day 5 or day 6 when we call the
Yes,
patient?
yes. Usually we see after fourth day of on the fourth day of stimulation. So on the fourth day you can assess her, and if you feel the follicles have increased in size from day two, then you can continue the same dose for another 2 days and then reassess again. Suppose there is no response at all and all of them remain to be between less than 5 millimeter only, then increase slightly by another 75 international units and check after 2 days.
Thank you.
Yeah.
Ma'am, why was in the second case that is why was karyotyping done for the patient?
Sometimes this congenital hypo they can have karyotyping abnormalities. So if at all anything associated with it, we were just as a screening procedure it was done. So more than karyotyping, what gives us is that single gene defects. But again, it is the chance of it getting transmitted or it is more of an sporadic event. So getting transmission to the offspring is very minimal. So we need not check for single gene defects in those cases.
Okay.
So, ma'am, in this case, you did karyotyping because the size of the uterus was very small, and it was by history we could make out that it is a congenital. By ultrasound we could make
Hypo.
out.
Yes,
So that's
yes.
why we did the karyotyping. Suppose
Yes,
by history we know that it is secondary hypo, then
then it
we
is
can.
not necessary. Yes. Secondary hypo, if you can correct the causes, try to correct them. Suppose if it is because of hypoprolactinemia or is because of certain drug intake, prolonged OCPs, in such cases where it is correctable or reversible, it is better to correct those and then proceed with normal stimulation protocols itself. Suppose where it is not correctable or it is more of a structural cause that has led to the secondary hypo, in such cases you can treat like I mean congenital hypo itself. So check. Yes.
And pizza, if it's 1% and less morphology and counts are also less, then only we go for pizza.
P
Usually, sometimes we'll be having severe roads, and if
severe
the
roads.
counts are also less and
Yes,
morphology is less
severe
than
roads better
1%,
to go with PISA like when the count is less than say 5 million and morphology is less than 1% or say 0%, motility is less than 5%. In such cases, better to go with PISA sample than using an ejaculate sample.
maximum how many days of stimulation can we take a patient? No? It usually minimum 10 days stimulation is usually required for everybody.
Yeah, it
Maximum
depends. Some do respond by 9 days of stimulation, some requires 10 days. So maximum
minimum 8 days at least everybody will require.
yes, minimum 8 days.
8 to maximum how many days have you seen patients requiring?
14,
Not more than
not more
8 to
than 14.
14 days. Okay, and another thing I want to know is how do we expect T2 levels based on the scan? Large
And
follicles 250
yes,
and medium size follicles, mid size follicles 200,
yes.
small follicles 100. We try to count
So
them.
try to count and you'll get an average idea how
Okay,
much
so
you'll have.
large is 250 and
Yes,
medium
medium
is
is
200
around 200. Rest
and
all will be
smaller
100 or less
100
than that.
100, 100
Yes.
around the count and and here RI is 3 and 0.9 the cutoffs.
Less than for PI, it should be less than 3. RI should be less than
Less
0.9.
than 0.9 on both
Yes.
sides or
Both
average should be
sides. No, average you can take, but it is better to assess both sides
individually.
individually and then you can decide.
Then increase the uterine size. Estrogen, suspension estrogen and progesterone is preferred over OCP use. OCP.
Definitely, definitely.
Maybe
Yes.
that's the reason why some people would be putting them on OCPs for long, still uterus wouldn't have grown.
Won't respond, but we have seen HRT they respond, especially even in POF patients who have already gone into failure completely, and if they come with hypoplastic uterus, in them also if you give T3 cycles of HRT, the uterine size will increase,
Regarding
and
with
they respond well.
hypoplastic uterus, it's better to go for
HRT,
sequential than direct
yes,
OCP.
yes, yes, proper sequential. 3 months is sufficient.
Minimum 3 months.
After three
Ma'am,
months, you
in
can
the
do a hysteroscopy and assess, and also scan. You can check for the
2.5 to 2.5
yes.
after that. And sometimes I've seen some companies marketing with HMG with traces of HCG.
No, no. In HMG, the LH activity is through HCG only.
Okay, ma'am.
we don't have the LH that is there. The LH activity is brought about through HCG.
Okay.
So the actual content, what causes the most of it, the 80% of the LH activity is brought about by HCG in HMG.
And because in HMG, we already have what? FSH and LH.
Yes. That LH activity is due to HCG in HMG.
Okay.
Yes.
Due to HCG and put
Yes.
some outside.
Yes.
So what we're getting is before the hotel HMG contains LH and this.
So that's why see, it is only highly purified version. Okay. So only in recombinant you get that pure form of LH. Here, in HMG, the LH activity is brought about 80% of the LH activity is due to HCG.
So this is the food traces of it.
Yes.
So some companies don't put food traces of HMG, but which
Some
is better to use now? For induction, should we use the plain HMG or the one with traces?
It all depends. Again, company how the purity. If you want the best one, then Menopure is the best. Mark what you get. Yes, that is the best quality that is available. Other than that, you want to go, then we have the next top quality. If you want, Humog is there. That is from Bharat Serum. Then there is Gynogen. All these three we have used, and there has been good response.
How would Pure Graph and these companies?
Pure Graph is also good.
Yes.
Pure Graph is also good. So basically, when you're using other like this new drugs, you need to assess whether the oocyte quality is good, you're getting good M2 rates, or whether there is too much of dark oocytes that is coming, or how is the fertilization rate, how is the blast conversion rate. So if that is not good, better to change to the other.
Because I've seen some companies very good like growth of the follicles, but
Yes.
pregnancy rates won't come up.
Yes.
Actually, in Pure Graph also we've seen how they will get very good follicles, but famine rate phosphates.
Yes. Whereas Menopure, we see the oocyte quality is good, and the embryo quality ultimately what we get is also good. So that costly, but still it is.
And in genetic testing, we when it is done, phenotyping is one most commonly done. Microchromosome microdeletion. What are the things? What should protein we send? Usually most common test.
In genetic test, most commonly it is we need to see for what reason we are sending for the genetic test. If it is just for an RPL or RIF where you want to just do a screening of karyotyping, then simple karyotyping is sufficient, because it is not possible to go and evaluate, or if you want to look at single gene defect, the cost of the test is very high. It's about 80,000. But and the chance of both couples carrying a very rare disorder, being single gene defects, non-consanguineous marriage, still carrying it is again a rare scenario, so we usually don't do it. But in those who are consanguineous marriage, they have had previous multiple miscarriages or multiple failures or abnormal babies being born where we need to evaluate further. In such cases, we do a test called couple carrier screening. Yeah, in that they check for some of the common single gene defects where they see if both are carrying the same single gene defect. Then there is a chance that the offspring might inherit it, and the miscarriage that could be the reason for miscarriages. So that is one test is usually advised in consanguineous marriage and those who are having an RPL kind of ATK.
So these are the three components.
Common. Y chromosome microdeletion advised in case of non-obstructive ASO, in case of severe OATs. Only in these two scenarios you will do the Y chromosome microdeletion. Or in case of male karyotyping, when you come across a karyotyping which says 46XY and there is minus Q. Y may minus Q. That means there is some part of the Y chromosome is missing. That's what the karyotyping report says. In such people also it is better to do a Y chromosome microdeletion. Fragile X syndrome, very early poor responders or POF, if they've gone into say by the age of 25, 26 itself, we see very early PORs. In such patients, yes, it would be useful. Otherwise, on a karyotyping role, nothing. Even in cases of RIF, karyotyping is done to rule out if there is any other translocations or anything. And in females, in case of low variant reserves also, you can do karyotyping. Young low variant reserve patients, you can do karyotyping. Males, severe roads or anything, or if they have a family history, say the male or the female, carry a family history of recurrent miscarriages within the family, then also karyotyping will be beneficial.
Specific genetic normality in the family,
then only we test for further.
And this couple can be screening for RPL,
RPL, if they are married within the relation and we don't find any other cause for RPL, then we can mark for this test. Or checking the microarray of the conceptors would be better if they have RPL, and if it's been checked, then we know exactly what is the cause, and that can be checked specifically again.
So, whatever we get the material, we send it for karyotyping only directly.
Karyotyping. These days,
Microarray?
yes, microarray or next generation sequencing. Microarray is more than sufficient to give most of the information. Microarray will cost around 20,000. Between 15 to 20,000 it will be from microarray.
They look at the same single gene defects in that microarray, in NGS and this one. And NGS, how much does it cost? No?
Little costlier than that. 20 between 20 to 25,000.
Around 25.
When we perform PGTA, it is NGS what is done most of the time. These days nobody does microarray. NGS is used for PGTA. Anything else?
Conceptors against them through the same years?
No. They'll have certain probes. Like one of the common causes for RPL, they have a preset probes. They'll check against that. And if the parent comes positive for any, suppose some particular disorder is found, then again we go back retrospectively check the parents for that gene. Yes, for that specific gene. If we find that, then they'll store it and keep. So when you're performing next IVF and going for PGTM that time, then they'll keep the same probe. They'll check only specifically for that particular gene. Yes.
You don't know what it is, then they do the whole
sequence.
test.
Yes, NGS only. Yes, full sequence they'll check. Whatever they have, they'll check. Sometimes if NGS does not detect anything, then you'll have to go for whole exome sequencing. Yes. Some of the defects are not seen in NGS, then you'll have to go for whole exome sequencing.
For exome repeats, maybe to look at the repeats.
Yes. See, one case I can just share with you. With a couple, it was a non-consanguineous marriage. First pregnancy, she conceived spontaneously. Then she had pontocerebellar hypoplasia, which was diagnosed at about 20 weeks, and the pregnancy was terminated. So the conceptus was tested, karyotyping came normal, microarray came normal. They did not find the cause. Second time she conceived, again the same thing happened. The fetus came as pontocerebellar hypoplasia only, and then again she had to terminate the pregnancy. That time they did whole exome sequencing. In whole exome sequencing, they came across a particular gene defect which will cause this pontocerebellar hypoplasia, and then the whole exome sequencing was done for both the couples. They're non-consanguine. So retrospectively, then they were evaluated. When they were evaluated, they were found to be carriers for that pontocerebellar hypoplasia. So next, we had done a PGTM for her, where we have kept the probe for pontocerebellar hypoplasia probe, that whatever the gene defect or the gene we want to see, and the same thing was checked for the embryos. So I think two embryos have come euploid and it is normal, which we have to transfer still. So it is normal. If you don't find anything and you still suspect a strong suspicion of any single gene defect, you go with the whole exome sequencing. Again, the cost of it is much higher.
Ma'am, I think that is why the concept of DNA storage has come. That if the results do not show anything, and if we have the DNA stored, we can go back and
go for further testing also. Yes.
So that is why we order DNA storage nowadays.
Yes.
Ma'am, can you please tell me once again the value of estradiol secreted by intermediate and other follicle size?
A lead follicle, a mature follicle will produce about 250 picogram per ml. The one which are intermediate ones will give you around about 150 to 200. The ones smaller ones are 100 or less than that.
Ma'am, smaller ones means in the range of 10
all
to
this 10 millimeter, 12 millimeter, those follicles.
And my intermediate is 12 to 16 or 12 to 14?
The ones which are 14 to 15, say 13 to 15, 16, those will give you around 150 to 200. The ones which are much smaller, say 10 millimeter, 11 millimeter, or certain 11, 12 millimeters also will be there. They also produce small amount of E2, that will be around say 100.
So, ma'am, when we are cautious about OHSS in an IUI cycle, are we concentrating more on these 10 mm and up to 15 to 16 mm?
So anything that is reached 15 and above, you got to be more cautious. So you need to count the number of follicles. That is not those which are more than 18 millimeter. Even those which are 14, 15, 13, you need to be cautious. And if you have a doubt, it is better to do estradiol levels and then decide on the trigger. You can go
usually
with
the estradiol do not correlate with the follicles.
If If you have given a lateral stimulation cycle, then it will not correlate, because laterals will
Yes.
cause this peripheral conversion, and invariably you will get very less C2 levels. It's so less that you might see it is like 50 or 100, less than that even sometimes, though there are about 4-5 follicles. So
So
that
ma'am,
time you have,
even if there are say 6 dominant follicles, but the E2 is coming as 500 because we have given Letros, so they
yes,
do they still have a risk of OHSS?
yes, definitely they do. So in case of IUI, if you are having more than 5, more than 4 dominant follicles, better not to do the IUI in such cases, because risk of OHSS is very high in them. Anything between 3 to 4, you can go with an Lupri trigger, not with HCG trigger, and then consider. A less than 2 to 3 is still safe.
And suppose 6 follicles have come up. We give a
Cancel.
agonist trigger. On the next day, the 2 dominant follicles rupture and the others have not ruptured. So 36 hours later, if 2 have ruptured, the others have not ruptured, and we put on a high progesterone support, then the other follicles should not rupture,
Yes.
no, ma'am? Because
It can
high
form a
progesterone.
cyst actually.
Yes, ma'am, they can form a cyst,
Hmm. But
but they
if it
wouldn't
is
rupture. So,
6, if you
hmm.
have 6 dominant follicles, better don't do IUI, because if
And if
she
the ma'am
conceives
not
the second
IUI,
time, yeah.
but can we go for timed intercourse? Because recently there was a patient who
The
came, he was
see,
not
see
ready
the
to abort.
problem, no, no, the problem here is not with the IUI, it is a problem of conception. So if she conceives, the chance of OHSS will really increase, and once it becomes late onset OHS, early onset is one which is easy to treat. Late
Yes.
onset OHSS which occurs because of pregnancy is very difficult to tackle, and it will only keep on increasing. So you
Mm-hmm.
got to be careful there. So you need to explain to them what risk they can have, and then advise them. You should in fact tell them not to keep contact and avoid
Mm-hmm.
IUI also. All the complications that can arise of OHSS and pregnancy should be explained to them. And most of them do
Mm-hmm.
agree in such cases. And initially itself, if you're seeing too many follicles are growing, then that time you can start counseling her. Or if you're giving gonadotropins, because of that the hyper response has started, you can stop the gonadotropins in between IUI cycles. Say you're seeing her on day 9 or day 10, you see about 5 follicles which have become dominant. You stop and see only the ones which are good, which has more number of receptors, will start growing. The rest might just shrink off. If not, and everything starts growing independently by its own, then better to cancel the cycle.
Okay, ma'am.
Dominant meaning anything more than 15 we are talking about. Okay. Not just which are 18, 20. Even more than 15 you got to be careful.
So, ma'am, please explain that small follicle size is 10 to 12 millimeter, intermediate is 12 to 15, and more
Yeah.
than 15 is dominant.
Yeah.
Okay, thank you.
Thank you.
Now, and it is like to give an agonist trigger in IUI cycle, then we give 2 mg, 2 right now. So we give 2 mg, and if in case after 24 hours of the scan it's not ruptured, should I repeat agonist only, or can I repeat it? If I change my mind, can I give HCG later?
You would have given agonist trigger because of the risk of OHSS if you're worried of. Wait till 36th hour.
So 2 mg, if it doesn't, we can wait till 36
Yeah,
hours
yeah,
like
yeah.
that.
Yes.
Provided we are sure
36
about the
to 40
storage and
hours.
the
Yes.
drug delivery, if we are sure about it.
Yes.
36 hours we can wait.
36 to 40 hours you can wait.
Maximum 40
Yeah.
hours.
Most 90% of the time they rupture.
Within 40
Suppose
hours.
if you're known case of LUF and she's not responding to that, then maybe, I mean, not in this cycle. In the next cycle, you can combine it with
DMC.
GCSF, dual trigger, or you can give GCSF also.
And if she is not ruptured till 40 hours, we can repeat 1 mg again or 2 mg again.
1 GCSF.
1 mg.
But then that time it's better to do your P4. There could be a high chance of luteinized unruptured
Yeah.
follicle. So you'll have to see for echoes within the follicle, and then if there is increase in thick walls, and if her PI is increased, all those things tell that it's become LUF. So then there is no point in repeating.
And if there is something like 3 dominant follicles, then is instead of HCG trigger is dual trigger better because HCG dose will reduce.
Yeah, you can give.
Is there any benefit in going for total? It's not 4 follicles.
Yeah, it
These
is 3,
follicles,
but
all
still
follicles are there, but intermediate follicles are not there.
not there. But still
Only
you're
4
worried of
follicles.
OHSS, you can give
Yeah,
dual trigger.
so dual trigger will be better than direct
Give
HCG
dual
trigger.
trigger. Maybe later on you can give her cabergoline also to avoid risk of OHSS.
Anyway,
Give
that
protein
isn't coming.
supplements, increase fluid intake in her. Give protein supplements. So that will take care of any mild form of OHSS. And then call her in between before her UPT to check if there is any free fluid levels. Just monitor her more frequently and explain her what complications can happen. That you're explaining.
And HCG dual is better, and then dual agonist is better.
Agonist is better.
For,
Yes.
Ma'am, in hypo HRT, how much estradiol are you giving, ma'am? 4 milligram or 6 milligram?
So usually start between 6 to 8 milligram. Okay, and they respond by about most of them they respond very well once you give HRT. Very rarely
Ma'am,
we see them coming with thin endometriums and all. So you starting dose can be between 6 to 8 milligram.
ma'am, what is the maximum dose of oral estrogens? Which
Total dose
we
of
can give
estrogen that you use should not be more than 12 milligram
in various forms, oral
per
as
day.
well as transdermal and
Yes, yes,
vaginal.
all combined together. Combined together per day, not more than 12 milligram.
and in there to go for underlying it is 1 plus 5,000.
No, no, you need not start with 12 mg. That is the maximum dose. If she's not responding, then only you go to that dose. So, what would be sufficient is 6 mg would be sufficient. If required, you can add gel formulation also, and that will come up to 8 mg. So, 6 to 8 is sufficient to start for HRT. Most of the time, 6 is more than sufficient. So, 6 mg you give for 25 days, and the last 10 days supplement progesterone. This is only for HRT.
All fours put together 12 is the upper limit.
Upper limit, yeah, safer limit.
And if anybody is not responding for 12 mg, can we go little above them? Suppose she's
In case you're increase, suppose she's not responded at all and you want to increase, what you can do is
and if she's low
maximum
risk for
14, not more, definitely not more than 14 milligram.
maximum 14.
But that time you go more of transdermal applications or vaginal formulations than going with oral formulations, where complication risks are high with oral, side effects are high with oral. Transdermal or vaginal.
And also, obviously, she's low risk for the other complications like
Yes, she should not be obese, she should not be hypertensive, diabetic, smoking, those cases definitely not till 14. 12 should be the yes cutoff.
only for those patients we can go to NGO.
Yes.
And the two keeping an eye on this.
Yes.
And not oral.
And oral treatment, better to go with transdermal or vaginal supplements.
Number prevention of OHSS. And if we do a cutoff in a stepwise pattern, like first add this, then this, or it is like straight away you start with all the category. In this stepwise we should follow.
It is like how you classify the patient first. Okay, whether she belongs to minimal, mild, moderate, severe, what kind of OHSS category she belongs to. If she's in the minimal or mild form, then your simple cabergoline would be sufficient for her, where you're trying to prevent it. She's not gone into frank OHSS, you're just trying to. For prevention methods, we'll use cabergoline, he starts using our agonist trigger. All these are preventive methods. But if somebody is already settled into OHSS by having gross ascites or having increased,
OPU on those days.
to be on the safer side, we add everything. But still, there's no harm in giving a one dose of Hestarch and giving one antag and cabergoline. Prevention is anytime better than cure. Better to be safe. It is okay to give 3 drugs and be safe in 3 days.
And we can also go home and just
Ma'am, which day of cycle you get to know? Suppose they are around the 15 follicles. Some of them are intermediate, some are 4, 5 are dominant. So which day of cycle you have to start? The day you get to know that yes, there are chances of
You're
OHS, we
talking in case of IVF stimulations, na?
IVF stimulation.
Okay, in IVF stimulations, usually cabergoline, we start only in cases where the E2 levels have gone very high, say more than 12,000. In such cases, we can start a little early on the day of trigger, little early before trigger. Otherwise, post OPU, you'll start all the supplements. So, doctor, you were asking, na? Somebody was asking when should we start cabergoline in case of IVF stimulation? It is not based on the number of whatever is the number of follicles, will continue the stimulation. Not to worry, even if it is like 25, 30, whatever is the dominant follicles or intermediates, will continue the stimulation. When we see the E2 is increasing or she's developing mild free fluid within the POD, then cabergoline can be started, say on the day of trigger, a day before also is fine. For 7 days can be given. And if E2 goes more than 10,000, if it's like more than 12,000, 13,000, in such cases you can give even letrozole 2.5 milligram BD for 5 days. That will bring down the peripheral E2 levels. Even if you started on the day of trigger, it will not impact the oocyte quality. But to be on the safer side, it's better to start after the OPU. If the E2 is very high, you can start it a little early also. Okay.
So, my meaning thereby, ma'am, the cycle has to be completed in most of the
Yes.
cases, and
Yes.
we have to just keep monitoring the levels. And capsuline can be started, should be started on the day of trigger or a day before. Earlier also we can start.
Better not too early on the day of trigger, or you can start it even after OPU if you don't have very high E2 levels, or if it is less than 10,000, she doesn't have any pain, there is no free fluid within the abdomen. In such cases, you can start it after pickup also. It is the PCV that you're going to monitor, not the E2 values. Both, I mean, if very high E2s, if she's going into OHSS, in such cases, low molecular weight heparin should be started post, because where PCV goes more than 45, then the risk of thrombosis will increase in them. In those people where you need to give low molecular weight heparin.
So, ma'am, at what level of E2 we should start monitoring these lab parameters like PCV?
Yes, yes, very important. That is how we monitor an OHSS patient. One is doing a serial scans for her and monitoring her ascites. What is the POD fluid levels, whether it is increasing or not, what is the size of the ovaries, and her discomfort level, her weight, her input output. And then next we're going to see her CBC, RFT. Okay, and LFT, these three things. LFT, RFT need not do regularly. It is the CBC which is most important. And increasing count, increasing PCV is what is more alarming. So total count and PCV, if it is increasing, then you got to be more rigorous in your management. Then you need to give her starch, more fluid intake, increase the protein intake, all those things. Suppose if these two are coming down, that is a good sign that she is recovering. Very rarely they worsen. Okay.
Okay, thank you, ma'am.
So that's how we monitor an OHSS patient. So call them daily. So these are the few parameters which has to be checked. We'll look for an ovarian size, look for the fluid levels, see for her CBC, PCV count, and then see for her weight, abdominal girth. All these things we monitor. So if everything is coming down, none of them are increasing, and patient is feeling comfortable, that means she is recovering well. If her abdominal girth is increasing, fluid is increasing, her weight, there is a significant, definitely we see a weight gain when there is fluid within the abdomen. So weight is increasing, PCV is increasing. That means gradually her OHSS is worsening, and we need to act immediately.
Suppose during the cycle only patient has gone into severe OHSS, then what will you do? We do the OPU, but we prepone the
Yes.
OPU.
Yes, in such case, suppose it happens like that, then you'll have to plan OPU early only. But usually what happens, even if like there are about 40 follicles that are growing, by the time we reach the trigger stage, so you need to be careful. You don't wait for all the 40 follicles to reach the dominant, where all of them become more than 17 millimeter. At least when you see majority of them are more than 17 millimeter trigger, you might get less number of M2s, but that is still okay. You can keep for in vitro culture and then convert them to mature oocytes. So don't wait until everything matures and then you plan. Uh, when most of the follicles are more than 17 millimeter, you can plan the trigger.
Okay, thank you, ma'am.
And we give it till
5
3 days
days.
starts.
5 days.
5 days,
Yeah.
not more than
Yeah,
that.
not more than 5 days.
And maximum GLH per day is 450. Like the maximum, maximum gonadotropin per day
It's
is
450.
450 what we go. Like that maximum for the whole cycle is 4,500, no?
Yeah, like 10
For the
days of
whole cycle,
stimulation if you take, then it is the
that's the
4500, but
capacity.
sometimes it can go till 12 days also.
Okay,
So,
so
so another 450, 800, you can go up to 5500 also.
5,500
Yes,
maximum per cycle is
yes,
what we go.
yes.
And
Very rarely we see 450. Most of the time 375 we see the response,
usually 360.
except in completely like obese who are about BMI of 38, 40. Such people will require 450. Otherwise, most of them respond by
375
375
is
dose.
practically
Yes,
what we go.
yes.
And
300 to 300 is more or less who respond most of the patients. If the response is not so good, only then we go to 375. 450 is very rare, and many studies have shown that there is not much significantly a difference in terms of response or the oocyte quality or the number of oocytes that is detected between 375 and 450. Because somebody who requires 450, though it doesn't mean her low ovarian reserve, we have to start with 450. Whatever follicle she has only will respond, and that might still respond to your 375 dose. So only those are not responding and obese, only then you go till 450. Yes, it does not respond. Yes, and high doses in case of any FSH-LH polymorphism patients. So in them, because of polymorphism, they do require a very high dose of stimulation. So in such cases, you can go with a higher stimulation. I mean, higher dose of stimulation.
Ma'am, what is the level of E2 to start the intake? Because somewhere it is given 200, somewhere it is given 300
E2,
picogram per
I didn't
ml.
get the question. E2 to?
Ma'am, what is the level of estrogen? We
Huh.
do serial monitoring and we start intake. So the
For
criteria for
antac
starting the
starting, anything more than 350 picograms, yeah, more than 350 picogram per ml, or you look at the lead follicle size also. If the lead follicle size is between more than 12 to 14 millimeter, then also you can start the antagonist.
Okay, thank you.
So by the time your follicle crosses reaches about 12 millimeter, definitely the E2 will be more than 350. So you can start at that time. So that's it. I'll end the session for today. Thank you. Yeah.
Thank you, ma'am.
Thank you, doctor.
Sometimes like usually we give one ampule. I've seen some centers giving two ampules per day of anti for OHSS.
OHS is, see, maximum you can give 0.5 milligram per day. So on the first day, like on the day of pickup, if the follicle we have retrieved like more than 20, then we give 0.5 and then we reduce it to 0.25. That more than most of the time, this is sufficient. 0.25 first day, 0.5 and then 0.25 for the next 2 days. That is sufficient to bring down the OHSS. Even if you have retrieved 40 follicles, they respond well with this dose.
Two ampules start followed by one ampule
Daily for the next 2 days. That is enough. 0.5 ml.
0.25, 0.5.
Yes. Okay. Thank you. Thank you.